folks. Welcome to Yale Cancer Center Grand Rounds. I'm Kevin Billingsley, and I have the pleasure of welcoming our visiting speaker today. Dr. Charles Balch is, no exaggeration, a giant of multidisciplinary cancer care and surgical oncology. We're thrilled to have him here today. Dr. Balch is a professor of surgical oncology and the past chair of the Department of Surgical Oncology at the UT MD Anderson Cancer Center. He has had an extensive and distinguished career as both a clinical and academic surgical oncologist, and he's one of the leading authorities in both melanoma and breast cancer care. Over the course of his career, Dr. Balch has made significant contributions to laboratory research in tumor immunology and human T lymphocyte differentiation. He started his medical career in med school at Columbia, and then he went on to surgical training at both Duke and the University of Alabama, followed by additional laboratory experience with an immunology fellowship at the Scripps Clinic, which clearly laid the groundwork for his seminal contributions in tumor immunology and melanoma. He's the founding editor-in-chief of the Annals of Surgical Oncology and editor-in-chief for the Patient Resource Cancer Guides, which are distributed to over 1 million patients every year. Dr. Balch has had an extensive history of prominent leadership roles in multiple centers across the country. He served as the executive vice president and CEO of ASCO. He's also served as the president and CEO of the City of Hope National Medical Center, as well as the chair of surgery at MD Anderson. Over the course of his career, he's accumulated over 700 publications across a variety of areas in research and clinical practice. And one of the things that in my conversations with him, he and I have truly connected on is the importance of leadership and community building around multidisciplinary cancer care and care coordination. So one of the things that I think I have taken away from my conversations with him that I'm sure he will be sharing today is the importance and our ability as oncologists to serve our patients in our communities in a variety of ways. And he's really shown how all of us can do this over the course of our careers, both through our direct clinical care, through education, through mentorship, through research, both clinical, translational, and basic science, through leadership and patient advocacy. So today he will be speaking on the role of surgery after neoadjuvant systemic therapy, and it is a real pleasure to have you here, Dr. Balch. Thank you.
Well, thank you, Kevin Billingsley, for a wonderful introduction, and I'm honored to be here with all of you today. So there are many themes we could talk about because we are now in a revolution of oncology care. Profound changes are occurring now. And I thought what would be important today as a theme to talk about how the field of surgery and surgical oncology is going to have to change and adopt to the new advances in molecular profile diagnosis, in systemic therapies, in immunotherapy, and the changes we are going to have to adopt to. So for some of you might say, that's not what I'm doing in my practice today, but I can almost guarantee you within the next 5 to 10 years, everybody in this room who is a surgeon is going to be impacted by the things that we're showing today. So as I go over some of these themes, I'd like you to think about the strategies that work in one tumor area, but understand that these are common to our understanding about the management of other cancers as well. That's particularly true in the immunotherapy field. So I've presented examples that I think are larger strategies that apply to our cancer care delivery system that is now being almost exclusively multidisciplinary. There are very few circumstances now where one modality in solid tumors will treat the patient anymore. So let me go over this. This is flying above the trees. Think about the strategies, not the details on the slides. And there are many things I can't cover in the time allowed that we can take for questions later on if necessary. So should I use this?
Yeah, you can advance with the keyboard if you want.
Okay. All right, well, let me start out with just the key messages of what I'm going to present as examples over time so that you can focus on the strategies. The first thing, because of the theme of this talk, is that surgery will not be the first treatment for most cancers except for stage 1 cancers. That's a revolutionary change, whereas heretofore, the patients usually went to the surgeon first, who then kind of coordinated the care. But now, because of these advances in systemic therapy, that surgery will not be the first. And we need to be part of a multidisciplinary team. And we must, I emphasize that, be involved in multidisciplinary treatment plans, because each of us bring to the decision-making a different perspective based upon our training and so forth. And it's the collective wisdom of the different oncology specialists that is really what's best for the patient. So all of us treating cancer in a specific disease need to be together and collectively decide on the best treatment plan for a patient. What's the right combination and sequence that involves all of our modalities? And that, as I'll show you, that the standard of care, what we call neoadjuvant surgery, I think our medical colleagues are beginning to talk about neoadjuvant surgery, that the primary treatment is systemic now, but it doesn't make a difference in the term. But what we call neoadjuvant therapy is now becoming the standard of care for many, if not most, cancers. And this is an area based upon clinical trials that is showing value in almost every cancer where it's tested. There's a few that are resistant, but if you think about the future and the advances we're making, this will be a common element of our treatment, that the first treatment will not be surgery, it will be a systemic treatment. And I'll go over with you about the value of that to the patient in their management. The other part of this is that immunotherapy now is the established fourth modality of cancer. But I want to emphasize as I get to the slide, this is a totally different treatment than the standard chemotherapy, targeted therapy, endocrine therapy that directly treats the cancer. Immunotherapy, these checkpoint inhibitors, do not treat cancer. And that has to be the first part of the logic, because we can't use the rules of chemotherapy when we apply to immunotherapy. It's a different process, and we're treating a dysfunctional immune system that is common to most cancers. So the other emphasis on this, because there's some emphasis, well, maybe we don't need surgery anymore, but I would argue that surgery is going to be incredibly important for staging, as I'll show you, as a reliable means of staging the tumor response and giving to the pathologist not only whether there's a complete response, but the residual tumor burden is now an important prognostic factor that is going to dictate our subsequent treatment. And then because of these advances in systemic therapy, that surgeons will no longer be performing the radical operations that we did in the past, because that was all that was available for many cancers. And so we'll be doing de-escalation, much more conservative, tissue-sparing, organ-sparing operations. And even if, as I'll show you, in 3 different cancers in our future, watch and wait, that we will not do surgery, we'll follow the patients. And then there's going to be a whole new lexicon that we'll need to do much more research on salvage surgery. Which patients can we select not to do surgery? How often do we follow them? What operation do we do when they relapse? And can we do this without compromising their survival by not doing an operation at the outset? And I'll show you 3 different examples. And then for those of you who are in training, that in all of us who are in practice, the field is moving fast in both the continuing education through organizations like ASCO, and in our training, we need to have surgeons who are trained in oncology. And as Kevin Billingsley and I've talked about, I really present myself because the way I think is I'm an oncologist who operates, because oncology deals with the chronic condition of cancer, whereas surgery deals with the episode of the operation and the perioperative period. But once the patient's wounds have healed, there's still an obligation for us as surgical oncologists to continue being involved in the long-term management of the patient. So that's the summary of what I'm going to talk about. I do want to just take a moment to say I predicted this 30 years ago in my presidential address at the SSO. And I wanted to point out what I said, because this was about surgical oncology in the 21st century. And I said that in the 21st century, only a minority of patients with cancer will have surgery alone as a single modality. And it's more likely that chemotherapy and even radiation therapy will be the initial treatment for many patients, while surgical treatment for some types of cancer will be relegated to a secondary or tertiary level. That was 30 years ago. And that prediction now is really valid for most types of solid tumors. So why is that? Because we're now in a new pathology with molecular diagnostics. In this slide, which is just a cartoon, showed the old way with these general diagnosis of solid tumors. We gave our therapy and hoped that 10% of the patients might respond, and we declared that as a victory. But now with genomic analysis, we select patients based upon their specific mutational events and other factors. And now, as you'll see, instead of getting 10% response rates, we're talking about 50 to 70% pathological complete responses based upon the selection of the patients and these new agents that are so much more effective. So as I mentioned, one of the things that is revolutionary is the advent of various immunotherapies, because we now have discovered, which is different than all of our strategies beforehand, where we assumed the immune system was deficient and we gave various forms of immune stimulants, which didn't work. So now we are discovered that in most human cancers that have survived in our patients, they've done that by releasing low doses of their tumor antigen and inducing tolerance, so that no matter how much you try to stimulate the immune system, it can't respond because it's in a tolerant state. This is no different than if you were allergic to grass and you go to the allergist. What do? They inject low doses of grass so that regardless of your exposure to grass, your immune system does not recognize it as not self and does not react to it. And so I think we've learned now that for many human tumors, and we're still sorting through this, but it is revolutionary as a discovery that a main reason that tumors have survived in patients we see clinically is because they have blindfolded the immune system into a tolerant state. So if we can unblindfold the immune system, we then have a personalized treatment that reacts against the specific array of tumor antigens in each individual patient. So if tolerance is broken, now then the immune system can reject the foreign invaders. And of course, there's a price for that when we're doing something profound by breaking tolerance, that the spillover is breaking tolerance to self-antigens. And so if you look at the array of complications we have with immunotherapy, you can explain them all as a form of autoimmunity. And that the good news is that we could treat autoimmune diseases with prednisone and taper those over time, reverse the toxicity. And interestingly, in contrast to chemotherapy, you can go back to the same immunotherapy in these patients. And surprisingly, they don't enter into toxicity the way they did the first time around. So there's a lot we have to learn about this. And I wanted to point out, of course, as you know, that Jim Allison and Tosoko Hanjo received the Nobel Prize for this. But I think another person who profoundly influenced the field that I wanted to give a shout out is here at Yale. And that's my friend who I worked with, Liping Chen, when he was at Hopkins, and we were working on melanoma immunotherapy. And I wanted to give credit to Liping, which I think is underappreciated by the rest of the world. He was the first to specifically state that a monoclonal antibody against B7H1 would break tolerance in a mouse model and therefore be an effective therapeutic strategy for cancers. And Liping worked with a group of us. This is Liping and Suzanne Topalian, who I helped recruit to the surgery department at Hopkins, and her husband, Drew Pardo, who was the chair of immunology. So this is an example of translational research in the collaboration with clinical scientists. So Liping's research directly stimulated Drew and Suzanne to take out a seed culture they had frozen to do a phase 1 study. They grew up this monoclonal antibody. Mike Carducci at Hopkins, the phase 1 director, gave it to a young person as an assistant professor named Julie Bramer, who is a pulmonary oncologist. And our recommendations was that you use renal cell and melanoma to test this new drug because everybody knows that's the only diseases that work with immunotherapy based upon the past work. But Julie came in one day at our Friday meeting and said, "You won't believe this, but my lung cancer patients are responding to this new drug." So BMS swooped in, bought the biotech company that had done the seed culture, and that became nivolumab. But it's a great example of collaboration between clinical and laboratory scientists that led directly to a major advance in cancer treatment. And I use this is an unusual example, but it shows the power of the immune system. This is a grapefruit-sized melanoma that was treated with a single dose of nivolumab and ipilimumab with a complete destruction of that tumor. That's a PCR after one treatment. And I use that only as an example to show you the power of the immune system when you take the blindfolds off, when you break tolerance. And that's unusual to have this, but as I'll show you, it's not uncommon either. So now there are 9 powerful checkpoint inhibitors with different mechanisms of action. And as we know with drugs, that when we combine drugs with different mechanisms of action, we can get an additive effect. So now we're showing that the combinations of anti-CTLA-4, which works in the central lymphoid section, and either anti-PD-1 or PD-L1, which works in the periphery, that the combination is better than either alone. And this slide just shows you briefly in a cartoon that they're now with different trade names, but the same types of drugs working in this signaling pathway between PD-L1 and PD-1, and a separate mechanism of the first drug, which was ipilimumab, which works in the central lymphoid tissue with a different mechanism of action. And now, even after only 11 years, when the first paper was presented, I'll show you a slide in a minute, you can see where the FDA has approved as an indication the use of immunotherapy, the same drug course. We're not treating cancer, we're treating a common deficit in most cancers that come alongside our traditional treatments to treat the patients with a variety of cancers. And every month there's new indications that are approved based upon what is now over 1,000 clinical trials going over various drug doses and indications for immunotherapy. So that those powerful drugs that were started out with advanced disease have now moved into the neoadjuvant space. And I want to show you the reason why that is valuable in neoadjuvant therapy. So from this wonderful paper from my colleagues at MD Anderson, that the advantages are, one, it downstages tumors and increases the ease of surgical resection. including, importantly, the conversion of inoperable or borderline operable tumors into operable ones. Importantly, as I'll show you, the pathological response is a surrogate endpoint for long-term benefit. So we could find out if drugs work within 6 weeks instead of giving them after surgery and following the patient for 5 years and then going back and seeing how many survived. So doing this up front gives us a better indication early on based upon the pathological response, and what you'll see is the residual tumor burden is important now in our cancer management. It allows us to test novel combination strategies and investigational drugs because we can take out the tumor after the exposure to these drugs and determine the new molecular profile of the cells that are refractory. And I'll show you a classic clinical trial that demonstrates that. And then the other reason is the improved responses are better than in patients with advanced burned out metastatic disease, where their previous chemotherapy itself is immunosuppressive and their volume of cancer itself provides an antigen excess, which is immunosuppressive itself. So if we're doing this upfront, when there's a smaller tumor burden, you get a better immune response. And then we have some molecular markers, the CPS score and other markers, but we really need better and more precise markers to help select our patients. So these are just a partial example of successful neoadjuvant trials that have led to approved indication by the FDA. And my point is, this is a range of cancers. This is a common abnormality to human cancers. And as we're learning how to use these checkpoint inhibitors in various combinations and sequences, they're adding to the advances of our cancer management, not as a substitute necessarily, but alongside as what I call the fourth modality of cancer treatment. So here's another hypothesis that has been proposed that I'll show you the results that led to a clinical trial. And as you could see in the upper cartoon, that if the surgeon takes out the bulk of the tumor and leaves microscopic tumor left behind and gives immunotherapy, there's not many cancer cells to stimulate the immune system. But on the other hand, if you give the immunotherapy up front, when there's a larger and more representative tumor burden and tumor antigen exposure, you will get a more robust and consistent immune response. And this is demonstrated amazingly in this randomized clinical trial, which proves this hypothesis. In fact, I'm astonished at the results. So this randomized trial gave everybody with metastatic melanoma 18 courses of a single drug, in this case was pembrolizumab. And they were randomized to receive 18 courses, but half the group got 3 courses up front and everybody else got 18 courses afterwards. So that was the only difference with this monotherapy. We don't use monotherapy anymore like this, but look at the difference between those patients who had 3 courses of single agent immunotherapy up front and those who didn't, which demonstrates what I just showed you in that hypothesis is the value in survival rates by giving checkpoint inhibitors before the bulk of their tumor is removed. And this gives the rationale for neoadjuvant immunotherapy. Another example that I want to show you from my colleague, Merrick Ross. This is a melanoma patient who presented with borderline operable bulky nodal metastasis in the groin and the pelvis. And this patient would have ordinarily had a radical dissection of the groin and the pelvis. After immunotherapy, with combination immunotherapy, you can see that there's a downstaging and the tumor size has decreased, so facilitating an operation. But it wouldn't surprise you that when all the tumor was removed, there was nothing left. The masses that we're seeing were inflammation and scar tissue in a classic rejection response, the same as what you'd see with a transplanted organ. or a viral infection, that the mass that we're seeing on X-ray was not tumor anymore, it was scar and inflammatory tissue. So the key point here is we can't gauge responses by X-ray verification. The surgeon needs to take it out, give it to the pathologist to determine the degree of response, and to do a new molecular profile to look at the molecular profile of the refractory cells. So this was the first immunotherapy trial presented in the world, 2010. So this is a very new field. This was using the maximum tolerated dose of a single agent, ipilimumab. And of course, the problem with this, although this became a standard of treatment until we found out that at that MTD, that 50% of patients had grade 3, grade 4 toxicity, and some patients died because of that. It was also shown that as a single agent, it's inferior to an anti-PD-1 checkpoint inhibitor. So in large part, this drug was not used anymore because of the toxicity. However, the teaching point here is you can't treat immunotherapy agents like drugs. And in fact, a dose now of 1 to 3 milligrams, which is not very toxic, when added to another checkpoint inhibitor, has an added benefit. So we have to get away from testing some of these agents by their maximum tolerated doses when actually lower doses work just as well, if not better, and are more tolerable. So I won't go over the details of this randomized study that looked at different dose schedules and doses of combining ipilimumab at 3 milligrams and 1 milligrams with combinations of Nivo. And this arm B, just to accelerate the talk, turned out to be the most efficacious and the least toxic. But here's the teaching point I wanted to make in this randomized study. This is the radiological response to patients being treated in this randomized study with metastatic melanoma, mainly stage 3. And you can see there's a complete response radiologically in 10% of patients, a partial response in 50%. However, when the patients had surgery and the pathologist could examine it, you see the difference. 57% of those patients had a PCR and 7% had a near PCR. So compare the difference between the radiologic response and what the pathologist found. You cannot look at these masses on X-rays and know what's inside them because these tumors, in many cases, are replaced by inflammation and scar tissue. So the surgeon has to take them out and give the specimen to the pathologist. And as I'll show you in tumor after tumor, the determination of PCR, near PCR versus more residual tumor burden is now an important part of our cancer management. But in my early days giving interleukin, interferons, tumor cell vaccines, if we had a 5% PCR rate, that was a victory. If we had a 15% partial response, that was a victory. And as I told one person earlier, we tortured people with alpha interferon over many dose schedules in years because that's all we had, and we improved survival rates by 2%. So now in this new era of melanoma management with the advent of immunotherapy, because we still don't have good chemotherapy, we have some targeted therapy. Look at the pathological responses now that range in this study between 65 and 80%, and pathological complete response in dose schedule B, PCR in 57% of patients. Never in the history of treating cancer have we seen these kind of dramatic responses. So this also shows you just in one other cartoon the value of combining 2 different checkpoint inhibitors which have different mechanisms of action. And if you look on the 2 pie charts, you can see that with an anti-PD-1, you get a 20% PCR. But if you add low doses of ipilimumab, you double that to 43%. So again, showing as we use with combination chemotherapy with different mechanisms of action, the new standard is using these combined checkpoint inhibitors. But the important point is the lower doses and shorter schedules work just as well as high doses given over a long time. because what we're doing is like turning on and off a switch. We're breaking tolerance, and I predict that we will not be giving a year of immunotherapy before we'll have to do the clinical studies to show that it's equally good of giving shorter courses. So this is one of my first key points about the impact on surgery. So this is a study, PRADA study going on now, which is a randomized study, but for which we have some of the early results. These are patients who present with stage 3B and 3C disease. They have clinically and radiologically detected nodal metastasis. An index node has a marker placed in the largest lymph node. Then the patient gets only 2 cycles of combination of immunotherapy, only 2 cycles. And then that index node, that's all that is removed. And you can see the strategy. Those patients who had a PCR or near PCR, less than 10% viable cells, had no therapeutic lymph node dissection and no adjuvant therapy. Whereas those that had a PCR did get a therapeutic node dissection and follow-up, and those that did not get a response had both a therapeutic lymph node dissection and adjuvant immunotherapy. But the point is that's already been reported is that in the patients entered into this trial, that 60% of them never needed a therapeutic lymph node dissection, which was their standard treatment before, because they achieved a PCR or near PCR. And I'll show you more examples of this in other diseases as well. So let me move on to breast cancer and neoadjuvant therapy. So there's another principle here that if we don't get a pathological complete response, you could predict that the residual tumors are going to be refractory to the drugs that you gave up front. So why continue them afterwards when these refractory tumors probably have a different molecular profile? And the strategy here, which is a classic and that I think applies to other tumors as well, was this Catherine study, which took HER2 positive patients who got neoadjuvant treatment. They all had residual invasive disease after getting their standard HER2 therapy, either single or dual targeted therapy, and then were randomized to switch their treatment if they had residual disease into a different drug, TDM1, or continued the same drug that they were on before. And this study, of course, showed that by switching therapies, intuitively this makes sense, you get an improved survival rate in those patients who we stopped after 6 weeks and switched to another therapy to treat the refractory tumors, and that in turn increased survival rate in these patients. And this has gone on in all the other subtypes of breast cancer. And my point here is you look at the residual tumor burden, which shown in the different colors, the differences in survival rates over 8 years based upon the subtypes of breast cancer and how those patients who have a PCR or near PCR do very well over 8 years. But in contrast, those patients who have more residual tumor burden obviously are going to need a different therapy and have a worse prognosis if we continue to give the same treatment and don't switch. And so now there are a number of clinical trials. I'm just showing one examples. It was showing that post-neoadjuvant treatment options, a different treatment than what was given up front, but directed by the residual tumor burden, because can improve survival rates with a range of switching therapies. So the teaching point here is now we have enough agents, we can go to second-line therapy early based upon the residual tumor burden after the surgeon takes the area out where the tumor was and gives it to the pathologist. So here's another important strategy is if we're combining chemotherapy with immunotherapy, that the chemotherapy that works directly on the tumor is going to break down the tumor into apoptosis. It will release tumor antigen, and in so doing becomes a boost, an immunological boost, or an internal vaccine, if you will, for the immune system where tolerance is broken. So it wouldn't surprise you if you use these combinations, you will get better responses. And in these non-randomized studies in the right, you can see the PCR rates was 60% or more. PCR by using a combination of neoadjuvant therapy. And in a series of trials, I'll just go over them quickly, the Keynote 522 and the Impassion 031, using different checkpoint inhibitors combined with the same classic chemotherapy upfront for 12 weeks, and then randomizing the patients between checkpoint inhibitors or placebo. You can see in both of these trials that the PCR rate was higher in both trials by adding immunotherapy to chemotherapy as neoadjuvant therapy. So now and this is only for right now been used in triple negative breast cancer, although there are recent studies to show that the addition of immunotherapy in selected patients with ER positive tumors also have an additive effect. But now with these advances and this shift, that neoadjuvant therapy is preferred in almost all breast cancer patients except for maybe stage 1A and 1B. And that is a profound change in how we treat breast cancer. And that a PCR is associated with markedly improved outcomes. And it gives us an insight within 6 to 8 weeks how well our patients are going to do, in contrast to our classic studies doing surgery first and then giving adjuvant therapy and then trying to measure 5-year survival rates 8 to 10 years later. So this is a very important advance. It allows us to keep moving on with new strategies in cancer management. The highest pathological response rates, around 63%, is used with the combination of pembrolizumab and a classic chemotherapy, carbotaxol, followed by ACEC. And the pembro not only improves the PCR rates, but also results in smaller residual cancers across the entire spectrum of disease. And that means it facilitates more conservative operations. It switches patients who needed a mastectomy for medical reasons into having the options of having lumpectomies because their tumors are smaller. So we also have learned that patients with residual disease have a poor prognosis and need additional or different treatment, and allows us, based upon the response, to individualize their therapy. So this is our future, not only in breast cancer, but in other tumors as well. So this is another part of our advance, which I'll show you in other diseases as well. I showed you in melanoma how we're now eliminating therapeutic node dissections in those patients who have a PCR. This is from my colleague Henry Kier at MD Anderson, who's presenting this information for the first time next month in Miami, and he kindly loaned me his slides to show to you today. So they have a prospective trial of eliminating breast surgery in selected patients who are exceptional responders to neoadjuvant systemic therapy. And the reason that they do this after their neoadjuvant therapy, and these are generally used with chemotherapy, that they use a vacuum-assisted core biopsy in the area where the tumor is, guided by ultrasound. And if there's no residual disease, they have no further breast surgery. But if they have residual disease, they get standard treatment. So Henry is presenting for the first time their multi-institutional study of 50 patients who had no breast surgery, whose average size at the beginning was 2.3 centimeters, and after a brief exposure to systemic chemotherapy was less than a centimeter. They had to do 15 vacuum assisted biopsies in these patients. But here are the results so far. 62% had a PCR. Among the triple negative breast cancer patients who had checkpoint inhibitors plus chemotherapy, was 71%, 55% in the HER2 positive. And what he's going to present so far, after 4.1 years of treatment with no surgical treatment, not a single patient has relapsed so far in the breast. And I could go over and show you other studies where we're now looking at eliminating radiation therapy in these patients who have a PCR. It's changing how we treat patients based upon their responses to neoadjuvant treatment. And they're now doing a study not yet reported in patients getting systemic therapy, standard lumpectomy, and being randomized to getting no radiation therapy to the breast if they had a PCR, including in their lymph nodes. So let me, as another example, go over lung cancer. This is another example where the molecular profile profoundly affects our targeted treatment, even in subsets of patients now of 3 to 7%. And in these small subsets, we not only have first-line therapy, second-line therapy, even third-line therapy for these small subsets defined by molecular markers. And as we do more of this, this is going to be the standard of care for all cancers, as our molecular profile allows us to select patients who are responsive to certain systemic therapy, but not for others. But I wanted to show you in terms of the immunotherapy, how these first studies using neoadjuvant therapy had a major pathological response in 45% of patients. But the reason I wanted to show these slides is this is an example published in the New England Journal of Medicine of the pretreatment imaging, and after 4 weeks, there was residual tumor. This was judged as a partial response. But when the surgeon took out that mass, there was no viable tumor left. And this is, again, illustrating in yet another disease the importance of the surgeon doing the staging and giving the tumor to the pathologist. Here's another example from the same article, fairly large tumor that didn't move at all. This was judged as a non-response, but nevertheless, the surgeons took it out, and that mass that you're seeing on X-ray was replaced completely by scar and inflammation. It was a PCR. So now there are randomized studies of neoadjuvant therapy. I'll just go over this quickly in the interest of time, using either nivolumab plus chemotherapy, platinum doublets, or pembrolizumab with essentially the same results in randomized studies. And you can see in this one study, checkpoint 8.6, that adding the PD-1 nivolumab plus chemotherapy was better than chemotherapy alone. And in this study now moving from stage 3 to stage 2 lung cancer also demonstrated that with pembrolizumab that you get an additive effect with a hazard ratio of 0.58 and a highly significant difference in event-free survival, and later on with follow-up in overall survival. So these two studies are just two examples demonstrating the additive value of checkpoint inhibitors plus standard chemotherapy. And the teaching point here is if you look at the responders and the outcome in the green lines, most of these patients will survive for a long time without relapsing. In fact, at MD Anderson in our melanoma group, my colleagues tell me that it is less than 5% of patients who have a PCR after neoadjuvant therapy have failed so far in their experience that now goes past 5 years. So let me show the last example on colorectal surgery, which is also another area where neoadjuvant therapy, here using chemotherapy and radiation therapy. And I don't have time to go over the details other than to show you in randomized trials, which I'll just briefly show you the results, different combinations and sequences of chemotherapy and radiation therapy up front has caused a pathological or near pathological complete response in almost 50% of patients. So again, just to show you the value of clinical trials in advancing our standards of care, these are two randomized studies showing different combinations and sequences of radiation therapy, both short-term and long-term therapy, and then whether the chemotherapy was given sequentially or simultaneously. But the bottom line is the patients who got longer exposures to standard chemotherapy as neoadjuvant therapy did better than those who got shorter courses. And this was shown in the Rapido study. This is a failure rate. Those patients who got longer courses of chemotherapy did better than those who had standard treatment. And in this Protégé study, now with 7 years follow-up, that the patients who got radiation therapy first, followed by long-term course of more intensive chemotherapy with FOLFIRINOX, did better than those who had the standard short-term chemotherapy simultaneous with radiation therapy. And now overall survival at 7 years, event-free survival shows a benefit of this, which became the standard treatment. And in the experience at MD Anderson, this is from our chair of colorectal department, George Chang. You could see those patients, again, that achieved a PCR did better with long-term follow-up. These were 18% of the patients, but no local recurrences and a very low risk of distant metastasis based upon the responses to the neoadjuvant therapy. Again, showing this in yet another disease as a strategy. And then finally, this Oprah study, which again randomized patients with different combinations of neoadjuvant chemotherapy, long-term radiation therapy, and chemotherapy, and then were randomized to receive either watch and wait if clinically and by X-ray they had a clinical complete response. They went into a watch and wait program. And the results of this were pretty striking. You can see that the patients who had the more intensive neoadjuvant therapy did better with long course radiation therapy, followed by FOLFOX. And the important point is that that I wanted to show here is the 3-year failure of event-free survival in patients who had no surgery was 53%. And if regrowth of the tumor, then all of these patients were salvaged with a TME operation. But in those who had shorter courses of chemotherapy did not do as well. But overall, as in this slide, nearly half the patients who received neoadjuvant therapy, especially with the longer courses of chemotherapy and longer courses of radiation therapy, you can see that half of the patients avoided surgery even after 6 years of follow-up. And those who recurred and had salvage surgery had essentially the same survival rates based upon the time of diagnosis as those patients who had surgery up front. So I wanted to finish with what I think is an example of our future when we have the biomarkers that can give us an exact prediction of response rates with checkpoint inhibitors. So a standard pathology report usually shows the immunochemistry results with either microsatellite instability high or mixed responses in mismatch repair deficiency, sorry. And the point here is this is for the first time that the FDA approved a drug with checkpoint inhibitors based solely on the molecular profile. So regardless of which tumor type it is, colorectal, gastric, pediatric, breast, sarcomas, which are very infrequent. The most common is in colorectal cancer, which is 10 to 15% of patients have these biomarkers, which is a surrogate for a poorly differentiated tumor. So think about it. The immune response is looking for foreigners, not self. The more foreign the object is in our body, the more robust the immune system is. So it shouldn't surprise you that the more poorly differentiated tumor, higher tumor mutation burden, or have these biomarkers are going to be the most responsive to immunotherapy. But this is dramatic. When the first studies were done, you can see there was a pathological response, major response in every patient who were treated with a checkpoint inhibitor. And look at these results. A single dose of ipilimumab and only 2 doses of nivolumab led to 100% pathological response in these patients who were MMR deficient, and even in 27% of those who did not have that mutation with this short-term dual agent. And as larger series have been presented like this at ASCO, you can see that 95% of patients expressing this biomarker, in this case in colon cancer, had a major pathological response and 67% had a PCR. with short-term dual immunotherapy based upon this tumor marker. And here's the other point: as larger series have been reported, again, using one dose of IPI and at a low dose, only 1 milligram per kilogram. Remember, we started out at 10 milligrams, which was too toxic. And that in 99% of patients, they had a pathological response. So this is pretty dramatic. Now, for the surgeons, this was published in the New England Journal of Medicine only on 12 patients who expressed this biomarker and who got a checkpoint inhibitor, and based upon that response had no radiation therapy and no surgery, and had been followed up now for more than 4 to 5 years. And these aren't small tumors. You could see in this example published in the New England Journal of Medicine, these were large tumors that over time with this checkpoint inhibitor disappeared. And in these patients with the follow-up with no radiation, no surgery, there were no recurrences based upon this tumor marker. So this also applies in the lower frequency of patients with GI tumors, gastrointestinal and esophageal cancers, which you could see in these studies using a combination of pembrolizumab and FOLFOX, achieved 23 of 26 patients were free of disease, and the overall survival in these patients who presented with advanced disease, treated with preoperative disease, and that 65% of those patients, based upon the tumor marker, it's a small percentage of patients, had a PCR with gastric and esophageal cancers. And now they're going on in this series of trials. The first one in cohort 1, they found a PCR in 60% of patients with this MMR deficiency. The major response was 80%. And now the next phase of this trial is those patients who have a complete or near complete response radiologically and endoscopically, get no surgery and follow-up for GI, for gastric and gastroesophageal malignancy. So I've shown you in melanoma, in lung cancer, in breast cancer, and now in colorectal cancer, based upon tumor markers and usually based upon combinations of checkpoint inhibitors plus chemotherapy, that we're now moving in selected patients to not doing surgery and watch and wait, and then follow up of the patients. And in those that fail, which is still the minority of patients, to do salvage surgery. So these are my summary slides. There are changes now, but these strategies I've told you are increasingly going to be applied for all solid tumors that will impact all of us in oncology fields. That neoadjuvant therapies selected by tumor molecular profiles is now and will increasingly become the standard of care for most cancers, for all but the earliest stage 1 cancers. And that surgery is vitally important for staging and local regional disease control. I've showed you data that there may be a place for watch and wait, but that's in a selected group of patients. And in everybody else, there's still an important role for surgery in staging these patients. And interestingly, now as we're doing less surgery for early disease, we're going to be doing more surgery for stage 4 and borderline resectable stage 3 disease, because we can downstage the patients. And those of us treating even stage 4 disease need to know whether the masses we're seeing on X-ray is inflammation or viable tumor. Take it out and do a molecular profile on those tumor cells that are not responding. So we need to better refine the role of watch and wait. This is a new thing. I'm not proposing it except in clinical trials. And the intensity of follow-up and the appropriate type of salvage surgery on relapse is going to be a new area for which we are going to need a lot of prospective data. And I think, as I've shown you, we're changing the standards of care based upon these prospective clinical trials that are neoadjuvant trials that involve surgery as part of the clinical trial. So surgeons must engage their patients in clinical trials where appropriate, and design surgical trials to document the results of de-escalation strategies, new sequences of treatment, and the results of salvage therapy. And I think for those of of us training residents and fellows that surgical training must include more exposure to contemporary cancer management, and that the pool of American Board of Surgery certified surgical oncologists must increase to meet the demands in the public to have surgeons who are also trained in oncology to be part of the multidisciplinary team. And as many of you know, at least in the tertiary hospitals, that in order to keep up with the rapidly moving field based upon one or two diseases, are increasingly going to have to focus their treatment to one or two organ sites in order to stay current with the rapid advances. So here are my key messages for the surgeons. One, to be prepared and informed to make major changes in the surgical management of your cancer practice, including deferring surgery until after a trial of neoadjuvant therapy because of the benefit I've shown you now in multiple tumor types. To consider surgical excision for borderline or inoperable tumors that are downstage with systemic therapy, and consider more conservative surgical procedures with the downstaging. And then we as surgeons have to adopt a mindset of being an oncologist who operates. Cancer management is dealing with now a chronic disease. Surgery is kind of a vertical specialty that focuses on the operation and the perioperative period, but our job is not done once the wounds have healed. There is another phase for which we need to be involved in giving systemic therapy up front and how we do what we do afterwards. And we also need to be at the arena when treatment plans are made to bring the surgeon's perspective to multidisciplinary treatment. And without being critical, I know that your medical oncology training and radiation oncology training does not include surgery as part of your training. And in fact, you're biased because you see our failures. I'll give you one example. My daughter, who's a PA in GI medical oncology at MD Anderson, sees a few of these salvage surgery patients and say, our patients come in with these huge, inoperable, miserable tumors. I don't see why we're doing salvage surgery. So I immediately called my son, Glenn, who's doing all the colorectal surgery, and said, yeah, that happens, but only in 5% of our patients. But my daughter thinks that we should be doing this because she sees the failures. The ones that do well don't go to those medical oncology clinics. So I think it's bringing the surgeon's perspective to those that are different in medical and radiation oncology. And it's the collective wisdom we all bring that is better for patient care decision-making. And then this last thing I don't have a solution for, but I want to give you an example. My son, Glenn, who's head of the division of colorectal surgery at Emory, had a conversation with his chair. So John Sweeney said, Glenn, I notice your RVUs are down. What's going on? And Glenn responded, well, half of my rectal cancer patients are getting a clinical complete response and going into watch and wait status. And now I'm flooded with these patients doing flexible sigmoidoscopy exams every 3 months, and there is little RVU values for this new group of patients. And so my point is, in this new era of oncology management, how are we going to gauge the clinical performance that heretofore is based upon volume of care when oncology advances in all of our fields are driving us to perform less intensive therapy? Surgeons are doing more conservative operation, less frequent lymphadenectomies, more watch and wait. Radiation oncologists are going from 6-week standard courses to 3 weeks to weekly to no radiation oncology. So there'll be less income if you're doing shorter courses of radiation. And of course, for our medical oncology colleagues, I think we're going to be giving shorter courses of adjuvant therapy, especially immunotherapy, instead of 1 to 2 years of expensive drugs. And then what are we going to do with these patients who are in watch and wait and are well patients that just need to be follow-up? The oncology specialist can't see the new patients and those under active treatment if they're seeing well patients for follow-up. So we have to delegate that follow-up to mid-level providers or even non-oncology trained physicians who will follow these patients and send them back in those few that relapse. And that's a change in how we manage our patients. It's a different team effect. But with like Glenn said, if half of his patients are getting a clinical complete response, he can't follow all of those patients for a lifetime. Somebody else has to do that and then send back those that relapse. So that's the end of my talk. I hope that this has been helpful in telling you about our present and future strategies and how that will impact on the surgical management of our cancer patients and the value of clinical trials in changing our standards of care. So thank you all for the opportunity of coming, and I hope this was helpful to you.
Thank you for a talk that was uplifting, exciting, and also provocative. I know the hour's getting late. There may be time for one question from the audience.
So thank you, Charles, for presenting, really just giving us food for thought and talking about where cancer care is and perhaps where it's going. I want to come back to your last point, which is interdisciplinary collaborations. And for the trainees in the room, I thought it'd be helpful to share a lens of, I was in Hopkins during that period, and many of those first offers were fellows. Patrick Ford, the lung trial you showed, and was a fellow sitting in a conference, and we were talking about this with surgeons, medical oncologists, and radiation oncologists. And the colorectal trials, my very good friend Louise Diaz, and I remember sitting with Louise, running our colon tumor board, and an observation that was made on a small trial, that on our phase 1 trial, one of the patients was mismatch repair. Efficient. It was one patient. And it was an observation made, and wrote Suzanne Topalian, who's a surgeon, as you mentioned, wrote that in a clinical cancer research. It was in a room smaller than this that led to this entire field of opening up in multiple tumor types from that very small population. So my question to you is that how do we encourage that as we're becoming bigger, that happenstance? That's how research is done. That's how great clinical initiatives happen. How do we foster that as leaders? We're sitting in this room, but that's a luxury that we rarely have. So I wonder what your thoughts are.
I think the answer is if we're looking for advances in care, see opportunities, and we can base a clinical trial prospectively on a hypothesis, or even retrospective data that leads to the design of the trial, that we need to be thinking about, we have to practice evidence-based care. And if we don't have this in this rapidly developing field, we're going to go back to empirical medicine based upon marketing of drug companies and instrument companies. So I think, to add to what Nita has said, that it's so important for us to insist on our patients, wherever possible, being in clinical trials where they're eligible, so that we can advance the field based upon evidence and not based upon marketing strategies. But we all need to have an open mind, and I'm enthusiastic about the results, but if you looked at the slides, there are a lot of patients who failed with our current treatments. So there's still a lot to do. And I think that's going to be based upon the team working together, each bringing different perspectives. I love the story with Lei-Ping Chen, who said, this works in the mouse, maybe it works in the patient. And he brought that hypothesis to what became a major immunotherapy advance. So the collaboration between the clinical teams and between the research teams and the clinical teams is, I think, what's important in championing the collective wisdom that we all bring with our different perspectives and bringing that together in our decision.
Thank you very much. I think Dr. Balch will be here for a little bit longer. I don't want to take more questions at this point. Maybe people can come down, and I know you'll be spending some time with the surgical residents. It's been wonderful.
Well, thank you all for the honor of coming here today. Oh, and I get the. You get this lovely.